Welcome to the diagnostic webinar series. This webinar is on cryptococcal antigen testing, and I'm going to take you through various aspects of this in the next few minutes. The learning objectives I'll cover in a minute. We're going to deal with how we diagnose cryptococcal meningitis and other forms of cryptococcal disease. We're going to show you how the kits are done and the actual procedures related to those, and then how to interpret titres that are positive for cryptococcus, and in particular the quantification of those titres. So our learning objectives today are to understand how cryptococcal meningitis is diagnosed, to understand how to perform antigen testing using several different kits, including a lateral flow device, and then be able to interpret the results for clinicians in the different clinical contexts in which these tests are done. So as I'm sure you know, cryptococcal disease particularly affects the lungs and brain. The organism is breathed in and then may disseminate to multiple organs, but cryptococcal meningitis is the most common manifestation. Sometimes you can have cryptococcal skin lesions as well, and these are actually more frequently found in histoplasmosis or talaromycosis than cryptococcus infection, but they do occur in cryptococcal disease, and sometimes you have subcutaneous lesions. Most patients present with a full-blown central nervous system infection or meningitis. Occasionally you can have limited disease to the skin, the prostate, the eyes, the bones or the joints, or a combination of those different organisms. Disseminated cases are often seen in severely immunocompromised individuals, particularly HIV and AIDS and transplant patients, but it's also seen in people without any apparent immune deficiency. So cryptococcal meningitis is diagnosed using multiple different methods, and today we're going to focus on the antigen method because that's the most sensitive and the easiest means of establishing the diagnosis. In some lesions, particularly skin lesions, but also in bone lesions or other biopsies, you can directly see cryptococcal yeast cells, and that's particularly true in the spinal fluid using an India ink stain, where cryptococcal yeast cells are quite easily visible, and you may occasionally see daughter cells attached to the larger mother cell. Patients with cryptococcal pneumonia have abnormalities in their chest X-ray or CT scan, which can be quite variable, but include cavitation and nodules. Once a specimen has been taken, cultures may grow. These do grow on blood agar, but they're better grown on specific fungal media, particularly Savarins media. And when an organism is grown, it can then be identified as a yeast. Further tests can be done to establish what the species of Cryptococcus is. Sometimes a biopsy is done, and cryptococcal organisms are visible on a biopsy, best visualized with specific fungal stains such as methylene silver or PAS stains, but they are occasionally visible on H&E, essentially as an organism with a halo around it because the capsule doesn't stain. Another means of identifying the organism is through molecular or Molditov identification systems, which we won't go into in any detail in this webinar. So the key specimens and approaches to making a full diagnosis of cryptococcal disease and assessing which organs are affected includes a spinal fluid, and an India ink stain is less sensitive than a cryptococcal antigen test, but it is a helpful test because if yeast are seen, then the diagnosis is clear. Fungal culture is important, but takes some time. There are clinical studies which have shown that quantitative fungal cultures are very helpful in monitoring a response to antifungal therapy. If there is a skin lesion, then a biopsy, or sometimes a scrape from the surface of the biopsy, can be done with fungal staining, and that can be cultured on fungal media. In the blood, cryptococcus may grow in the blood. It may be mistaken for candidemia, and that's important because the kinocandins are inactive against cryptococcus. Cryptococcal antigen can be done, and it can be quantified in the blood as well. Occasionally urine or seminal fluid can grow cryptococcus, and that's helpful for assessing patients who may have prostate disease. And respiratory cultures are sometimes positive as well in patients with cryptococcal pneumonia, which can be as a sole disease or as part of a disseminated disease. So the sample types that grow cryptococcus are typically spinal fluid, blood, and skin biopsy, sometimes respiratory fluids. Most of the time, cryptococcus can be isolated in patients with cryptococcal meningitis, but the antigen test is more sensitive than culture. Blood cultures are positive in 35 to 70% of patients with cryptococcal meningitis overall. The best temperatures for incubating cultures are 30 to 35 degrees on multiple media. It's not a difficult organism to grow, but it can take 2 to 5 days to come up. The colonies are white, green, mucoid, almost milky-coloured colonies, and then they, over time, turn orange, tan or brown, and they produce melanin typically. They're grown in aerobic culture. This organism doesn't grow well in anaerobic culture. And you have to keep the plates for at least 5 days and preferably up to 4 weeks to be sure the cryptococcal cultures are negative, although the vast majority of isolates will grow in 5 days. Birdseed agar is useful specifically to separate Candida from Cryptococcus because the colonies of Cryptococcus go black on birdseed agar, whereas the Candida colonies do not. Cannabinoid glycine bromothymol blue agar can be used for distinguishing the Gatti from the Neoformans varieties or species of Cryptococcus. And there's better encapsulation on chocolate media than there is on bird agar. Microscopy can be done principally on spinal fluid, but sometimes on other secretions, or, for example, from an aspiration from an abscess next to a bone. India ink or nigrosand can be used as the background stain, and encapsulated elongated yeast cells called Plastoconidiaceae. That's the most rapid method of identification. India ink is positive in 70 to 80% of patients with cryptococcal meningitis, but only 30 to 50% of HIV negative individuals with cryptococcal meningitis. And patients who have persistently positive India inks on treatment, this signifies treatment failure usually. So it can be a helpful test, but it does take quite a long time to clear India ink microscopy positive, particularly in patients with HIV disease who have very high numbers of cryptococci in the spinal fluid. Patients with HIV sometimes have cryptococci with very small capsules, and they can look like lymphocytes, and sometimes there are more cryptococci than lymphocytes, and that can be a misleading image microscopically. And as I've indicated, India ink is less sensitive than cryptococcal antigen. On tissue, cryptococcal yeasts have a narrow-based bud, unlike blastomyces, for example, and PAS stain produces quite a marked pink colour, and as does mucicarmin, which is a specialised stain for Cryptococcus, which is used occasionally. Cryptococci also produce melanin, and that can be visualised on the Fontana mammasen stain. If you use direct microscopy with calcofluor or blancophore, this organism also has a bright capsule which can be visualised with these fluorescent brighteners. The differential diagnoses, histologically, a histoplasma, which usually is smaller than Cryptococcus, big 3 to 5 microns across, but Histoplasma duboisii, or the organism causing African histoplasmosis, is quite a bit larger, and they do have narrow budding yeast cells. Candida glabrata is usually a small yeast, but can be larger, up to 15 microns, and there are no pseudohyphae seen with that, and pseudohyphae are very rare with Cryptococcus. So the antigen test depends upon the release of carbohydrate from the cell surface and the cell capsule, and it can be done on multiple specimens, serum or plasma, finger prick, a whole blood, spinal fluid, urine, although it's less sensitive in urine, and BAL or bronchoscopy fluid. It can be used as both a screening test and as a diagnostic tool. The sensitivity with latex agglutination is between 93 and 100%, and specificity is quite high at 93 to 98%. The lateral flow assays, which have been principally done in HIV patients, are at least 99% sensitive, and they're highly specific as well. And those figures relate to serum, plasma, whole blood, and spinal fluid. In urine, the sensitivity is about 85%. There are false positives, usually at low level. These include rheumatoid factor, the organism trichosporin, which is a cause of fungemia, particularly in cancer patients, produces an almost identical antigen and gives you a true positive result, but it's false positive for Cryptococcus. There are a few other organisms that can produce a low-level false positive, including Stomatococcus, mucinaginosis, Klebsiella infections, and cineresis or plasmaresis-like fluid can also give you a false positive. In the older latex agglutination assays, there were prozone effects where very high antigen titers would produce a false negative. And there are patients with extremely low levels of cryptococcal antigen, particularly non-immunocompromised patients who have a chronic hydrocephalus presentation. And these can be false negative, particularly on latex agglutination. And poorly encapsulated or encapsulated strains have lower levels of antigen, but it's usually still positive. So the advantages of the cryptococcal antigen assay using the LFA methodology is that you have a fast turnaround time. It doesn't take very much laboratory equipment, so it can be done at the bedside if necessary, or serum or plasma can be centrifuged and then the sample run. There's no pre-treatment of the sample required. The test is stable at room temperature, including quite high temperatures in the tropics, and it covers both the Cryptococcus neoformans and the Gatti antigen. It's important because there are occasional patients with Gatti infections who otherwise were missed on some of the older tests. It's not quantitative in the first generations of the LFA tests, but the more recent ones have got a double band which show two different levels of positivity. And if the higher test is positive, then that usually means the patient has meningitis. There are these older tests. Here's an example of the Meridian latex agglutination test, which was the standard test for several decades and is still used and is helpful, but not quite as sensitive as the LFA test. But it does produce a quantitative answer. It's not as easy to generate reproducible results because of the dilution issues that have to be very carefully done, particularly in patients with a very large amounts of antigen. There are EIA tests, so this is an example of the IMI EIA test, which gives you an OD on an ELISA reader, and there's an alternative from Meridian with a different EIA, and there are other companies with EIA tests as opposed to latex agglutination tests. So we're going to show you a number of different procedures from different tests that are available currently. There is a move to have dual titer antigen tests, and not all of these have been fully exemplified and launched into the market, so it's important to keep up to date with new developments in this area over time. But this introduction will be very helpful, I think, in showing you how simple these tests are. To remind you, a lateral flow test is quite carefully built, and in the bottom panel here on this image you can see you have a test line and a control line which are detecting the first antigen from the infection you're interested in, and the control line just to check that the sample has flowed correctly down the pad, that the test is actually working in a functional way. And if you look at the middle image, you can see that you have a sample pad, and that's where the sample goes. And then it gradually migrates down through the test, and then it's absorbed in the wadding pad at the far end. And the top example shows you exactly what happens. So the clinical sample goes on the pad. There are monoclonal antibodies linked to colloidal gold. There they bind to cryptococcal antigen if it's present, and then those are detected as the sample, and these conjugates move further down by the test line. And there's a similar event happening with the control line with the different structure of gold and control positive sample. So now you're going to hear about the Biosynex CryptoPS test, which is a semi-quantitative LFA. Biosynex CryptoPS assay can be used on whole blood, serum, plasma or spinal fluid. When you open the box, you'll find inside all the reagents that you need apart from pipette tips and pipetta. You should read the instructions for use before you do the assay if you haven't done it before. There's a barcode card present. Each of the cassettes is individually wrapped in an aluminium pouch. And you will find two bottles of liquid, one which is a diluent bottle for doing titrations, and the other which is the diluent dropper bottle for running each assay. And there's also a positive control bottle if you want to do a positive control to check on the results. So In this example, plasma is going to be used. You take an individual cassette and you remove it from its pouch and you place it on the bench in front of you. You then use a pipetter that allows you to pipette 20 microliters, and you take your sample, which you vortex prior to insertion into the S-well of the cassette. And then you take the dropper bottle and you add 3 drops of the diluent into the same S-well of the assay. You start the timer for 10 minutes and you can see that you could get 3 lines. You should have a control line and you can have a low concentration positive or a high concentration positive. The test should be read at 10 minutes and not at 15 minutes. This example is a low level positive. The next assay that we're going to show you is the CrAg-LFA, which is available in many countries.
In this video, we demonstrate how to perform dynamic cryptococcal antigen lateral flow assay, also known as CrAg-LFA. To perform the test, ensure that you have pipette 100 microliter or 200 microliter. Tips: timer, tube rack. 1. Open the kit and take out test cord from the foil pouch. Place test cords on flat and clean bench. 2. Add 80 microliter of serum or CSF samples into sample pad. 3. Read and record the result after 15 minutes. Inaccurate result may occur after 20 minutes. Interpretation of results: positive, negative, invalid. Thank you for watching.
The third assay we're going to show you is the Histopathology CrAg-LFA. Not very much is published about the performance of this assay. We hope this will be remedied soon. This is the Histopathology LFA, suitable for serum and spinal fluid. The procedure is relatively straightforward and each sample is vortexed prior to analysis. A separate tube is prepared for each sample. And then the kit has all the reagents that you require apart from a pipette tip and a timer. You use a pre-treatment solution for each sample. And you place 1 drop of this pre-treatment solution into each additional tube for each sample that you will be running. You then transfer 50 microliters of sample into each of these tubes, using a separate pipette for each one. Each tube is closed and labelled. It's important that you know which sample is which. And then each sample is then vortexed. You're now ready to start the assay. So take one of the case sets out from each foil bag and place it on the bench so that you can see the upper side. Label each cassette with the sample number so that, again, you're confident which sample is which. Then you take 50 microliters of each of these pre-treated samples and you place it into the well of each of these cassettes. Use a different pipette for each pipette tip for each sample. You then set the timer and it should read 10 minutes. And then you have to read the assay and you either get a positive or negative, and we will then complete. There are positive and negative controls used, and you can run these to check that the kits are working if you so wish. And this is a good idea for each new batch. Here the example of these is going to be run partly to show the control lines and the test lines. Again, these should be labelled so you know which one's which, but this should be obvious from the results. Again, this assay is run for 10 minutes with the positive and negative controls. And here are some examples. You can see the positive control has got 2 lines, negative control 1 line, and each of the sera samples that were run were both negative and both have a control line but not a test line. And the final assay we're going to show you of the LFA variety is the LFA, which was the first to be launched on the market and is used extensively in Africa and other parts of the world.
Cryptococcal meningitis is one of the deadliest opportunistic infections in HIV patients. It accounts for about 500,000 cases per year. Early detection is key to improving outcomes, and one of the ways to do this is by performing the cryptococcal antigen lateral flow assay, also known as the CrAg-LFA, on blood. And here is how to do it.
Hello, how are you?
First, clean the patient's finger with alcohol, then prick the finger with a lancet. Place a small droplet of blood at the tip of the CrAg-LFA. Then add 1 drop of specimen diluent into a reservoir. Insert the test strip into the reservoir. After 10 minutes, examine the strip and read the results. 1 line for control means negative. 2 lines mean positive. Make sure the control line is visible, otherwise the test is not valid. It is important to wait the full 10 minutes because results are not always immediately clear, especially in patients with low fungal burden. However, once 2 lines are visible, it is positive. Performing CrAg-LFA enables healthcare workers to diagnose cryptococcal infection quickly and get a head start on management. More information is available on preventcrypto.org. Thank you for watching.
The final section of our webinar is explaining how to interpret these tests and how to decide whether to quantify or not. We're next going to show you how you can actually produce a semi-quantitative answer from the IMI LFA, because it is helpful in the field to sometimes know if you have a very high titer or not. And in patients who have iris syndromes or patients who have other problems where it's not clear whether they're responding well to therapy, this is sometimes really quite helpful. So there's a video showing how to do this semi-quantitative method.
Following a positive result, the semi-quantitative procedure can be run to determine the titer of the specimen. Prepare dilution starting with an initial dilution of 1 to 5 and follow with 2-fold serial dilutions up to 1 to 2560. First, place 10 microcentrifuge or test tubes in an appropriate rack and label them 1 to 10. Add 4 drops of lateral flow specimen diluent to tube number 1. Add 2 drops of specimen diluent to each of the test tubes labeled 2 through 10. Add 40 microliters of specimen to tube 1 and mix well. Transfer 80 microliters of specimen from tube 1 to tube 2 and mix well. Continue this dilution procedure through tube number 10. Discard 80 microliters from tube number 10 for a final tube volume of 80 microliters. You are now ready to submerge your tests. To reduce the total number of strips required for running the titer, we recommend following our titration algorithm. Begin by placing test strips in the tubes numbered 4, 7, and 10 and wait 10 minutes. These tubes will provide parameters for running the remaining dilutions. If tubes 4, 7, and 10 are negative, test tubes 1, 2, and 3. If tube 4 is positive and tube 7 is negative, test tubes 5 and 6. If tubes 4 and 7 are positive and tube 10 is negative, test tubes 8 and 9. If tube 10 is positive, perform more dilutions or report as greater than 1 to 2560. Conclude by reporting the titer as the last positive dilution.
And then the interpretation of the cryptococcal antigen assay, and if it's been quantified, is going to be explained to you by Dr. Radha Rajasingham, who has been involved in this area of research for a long time.
Quantification of cryptococcal antigen titers. Our learning outcomes for today's presentation are to learn how to measure different cryptococcal antigen titers and report them, to understand the diagnostic value of CrAg titers, and to understand the value of cryptococcal antigen titers to monitor disease and/or therapy. Throughout this presentation, I'll use the abbreviation CrAg, which stands for cryptococcal antigen. How to measure CrAg titers. On the right, you can see the latex agglutination test. 2-fold dilution of CSF or serum using this latex agglutination test historically has been the conventional method for measuring cryptococcal antigen titers. But cryptococcal disease and HIV can yield very high titers, and this dilution becomes time-consuming and expensive. Below is an image of the CrAg lateral flow assay, which is a more simple point-of-care test to detect cryptococcal antigen. Both the latex agglutination and the CrAg lateral flow assay can be quantified using titers. Both are performed using serial dilution. The titer is the last positive test before the dilution turns negative. Titers across the latex agglutination and lateral flow tests are not comparable. CrAg dilution series. Generating the most useful quantitative data of CrAg titer is not yet standardized. This table illustrates some options for dilution series. On the left is the conventional method of twofold titers. On the right is the IMI-recommended dilution series for the lateral flow assay. In the center is an example of a dilution series where using a threshold of 1 to 160 would minimize the need for multiple dilutions. We will shortly review the data behind this threshold of 1 to 160, as this is a clinically valuable threshold to guide management. What is the diagnostic value of CrAg titers? The graph on this slide depicts the correlation between CSF cryptococcal culture on the y-axis and CrAg lateral flow assay titers on the x-axis in HIV-infected persons in Uganda with cryptococcal meningitis. The culture and CrAg titers results correlate strongly on day 1 of enrollment. This value of titer to predict quantitative culture decreased over time and was no longer seen 7 or 14 days later. This figure highlights the strong correlation between CrAg titer and CSF cryptococcal culture. Furthermore, CrAg titer is associated with survival in HIV-infected people. This figure combines 4 African cohorts of asymptomatic HIV-infected people screened for cryptococcal infection and treated with fluconazole. Here we can see the effect of CrAg titer on 6-month survival. Those with a high titer had low survival. Among asymptomatic CrAg-positive persons, CrAg titers of 1 to 160 or greater are associated with increased mortality despite receiving standard of care antifungal therapy. From the same cohort, we see that in asymptomatic HIV-infected persons, as serum CrAg titer increases, the probability of CSF involvement increases. On the left panel, you can see that in asymptomatic persons with high CrAg titers, those people are more likely to have subclinical cryptococcal meningitis. On the right panel, we see that as CrAg titer increases, those with symptomatic CrAg-positive CSF increases, i.e. meningitis. Serum CrAg titer of 1 to 160 or greater is predictive of meningitis with a sensitivity of 88% and specificity of 82%. How about cryptococcal infection in non-HIV infected patients? In this study of solid organ transplant recipients, 83% of those with pulmonary cryptococcal disease had a positive serum CrAg test. Overall, 48% of these patients with a positive cryptococcal antigen had extrapulmonary disease, compared to 13% of those with a negative CrAg test. CrAg titer was significantly higher in people who are fungemic compared to non-fungemic patients with pulmonary cryptococcosis. CrAg was less likely to be positive in those with a single pulmonary nodule compared to those with multiple pulmonary nodules. Mortality at 90 days did not correlate with serum cryptococcal antigen positivity. Median CrAg titer in patients who died was 1 to 256, compared to 1 to 64 in those who survived. In HIV uninfected people with cryptococcal meningitis, high CSF CrAg titer at baseline is associated with sensorineural hearing loss, neurologic sequelae, cryptococcal meningitis relapse, and death. Finally, what is the clinical utility of monitoring CrAg titer over time? Follow-up monitoring of CrAg titer is not useful in HIV-infected persons with cryptococcal meningitis. No difference has been seen in those who've had clinical response to treatment versus persistent disease or cryptococcal relapse. Furthermore, in HIV-infected people with asymptomatic cryptococcal antigenemia, change in serum or plasma CrAg titer is not associated with survival. The figures below depict CrAg titer values for patients with asymptomatic cryptococcal infection, both at baseline and 6 weeks thereafter. The left panel displays those who survived to 6 months follow-up. and the right panel displays those who died before 6 months. There was no statistically significant difference in change in titers between those who survived versus those who died. To summarize, what is the value of cryptococcal antigen titers? Any positive CrAg in the serum, plasma, or CSF is associated with disease and needs evaluation and consideration of treatment. High titers in the serum at baseline are associated with meningitis, neurologic sequelae, and death in both HIV-infected and HIV-uninfected cohorts. In HIV-infected persons with asymptomatic cryptococcal antigenemia, high titers in the blood are predictive of subclinical meningitis and death. The best cutoff for predicting meningitis in HIV-infected persons is a titer of 1 to 160 or greater. Finally, there is no value in monitoring CrAg titers over time in HIV-infected persons with cryptococcal meningitis or asymptomatic cryptococcal infection.
So, in summary, the key elements of diagnosing cryptococcal disease include microscopy, histopathology, culture, biochemistry of the spinal fluid, radiology, and molecular identification or other identification of the organism that's grown. And the tests will vary depending on the disease manifestation and the sample type. But a more sensitive test and a more appropriate test in most circumstances, but not all, is the cryptococcal antigen test. You could use a latex agglutination, but also EIA or a lateral flow assay. And most people use the lateral flow assay for its simplicity and sensitivity. It's quick and it can be used semi-quantitatively, and it's highly specific. And because the LFA requires minimal laboratory infrastructure, it's suitable for many low-income or middle-income environments. But it is also used in many high-income countries as a screening test prior to doing a semi-quantitative answer. A titer of more than 160 is suitable for diagnosing or is appropriate for diagnosing cryptococcal meningitis in an HIV patient, and it's always best to do a lumbar puncture. The benefit of lumbar puncture includes measuring the CSF pressure and also being able to sample the fluid to be sure that that is the right diagnosis. You can occasionally get false positives in blood, but not in spinal fluid with a cryptococcal antigen titer. And false negatives rarely occur because of poorly encapsulated varieties of Cryptococcus. Thank you very much for your attention. There are various other resources that you can access, including on the Life website and YouTube, multiple other videos which would may be helpful to you, and also a microscopy course that may be valuable for you. Many thanks.
Thank you, David. Very illuminating and exhaustive review of cryptococcal antigen testing. So we're waiting to see if any of our participants from China have any questions. We encourage them to ask you some questions, but I will start off. So as we've done before, if I ask the question, Sophia, who's here with me, will translate, and if you could answer, if you like, line by line, she can then translate your answer.
非常感谢大家的观看。现在呢，进行提问和回答时间。我的同事 Malcolm Richardson 会替大家问问题，我将会翻译，然后David 在您将会回答大家的问题，我会逐步的翻译给大家。
So let's start off. We've been talking and we've been hearing about the optimal samples for using the lateral flow devices. You may remember just a few years ago, one of our former master's students published a paper on the use of saliva as an alternative specimen type.
现在呢有很多研究想找到取代常规样品的方向。我们曾经的一个硕士学生在这里学习的时候，现在发表了一篇关于用唾液进行侧向免疫层析来检测隐球菌的方法。
So saliva has really only been used in this one
experiment in Uganda in a large sample of patients, and it was found to be much less sensitive than blood or spinal fluid for detecting cryptococcal antigen.
只有一个研究在乌干达进行的研究显示，用唾液进行检测远没有用血液和积水液更敏感。
So something else, of course, which is of concern, considering where some of these devices are used, is how stable are they at room temperature or ambient temperature?
这些试剂盒在室温下是否能持续有效呢？
So the normal shelf life of a cryptococcal antigen LFA is about 18 months or maybe as long as 2 years. But that does assume that they're stored at what I would call normal room temperature, so between 15 and 25 degrees C. We have seen some quite extraordinarily high temperatures in parts of the world, and I don't think these tests have been stress tested for example, storage at 35, 40 or 45 degrees C. So I think there's a little uncertainty. So if there's air conditioning, then that would be a good place to keep them in the long term if you have a very hot environment outside.
在室温常温下，一般在18到25摄氏度左右的话呢，如果放在这里的话也可以。在特别炎热的地方呢，像35度以上的话，也并不建议放在常温下。如果有空调啊，或者有一些温度控制的设备的话，也可以放在常温下保存的。特别是免疫承吸设备。
So I was interested in your comments about the strains of Cryptococcus which really don't have a capsule.
有一些隐球菌并没有荚膜。
I remember there was a series of papers that were published from New York many years ago now in HIV positive patients. There it was claimed that these isolates did not have a capsule.
在纽约发表的一项研究显示，很多艾滋病患者的那个培养的菌落里面，它的隐球菌并没有荚膜。
But you've been telling us during this webinar that you can detect polysaccharide cryptococcal antigen from acapsular strains.
在这个视频当中，你说过可以通过检测荚膜来鉴定隐球菌的感染。
So there are two issues here. One of them is that the isolates with very little capsule may be mistaken for lymphocytes.
没有荚膜的可能是因为被错误的鉴定为隐球菌，可能是淋巴血红细胞。
And the second issue is whether these strains produce cryptococcal antigen, and the answer is that they do. Probably the antigen is not bound very well to the surface of the fungus and is released into the environment more easily.
也有可能它的抗原并不是很好的紧贴在细胞上，而是到所生存的环境当中。
Right. So another question that comes up frequently is, do these tests actually detect antigen that's been released by other species of Cryptococcus beyond Cryptococcus neoformans?
这些检测是否能检测到除了新型隐球菌抗原之外的其他隐球菌的其他隐球菌呢？
It's a very important question because many of the infections in non-immunocompromised patients are caused by a Gatti variety of Cryptococcus.
也有可能是有些隐球菌感染可能是由格特隐球菌引起的。
And some of the antibodies which bind to the antigen are broad spectrum and cover all the strains or species. Some are less active against some of the different species.
有一些抗体呢，就是可以检测的比较广泛，有一些抗体呢是比较有特定性的。
I do know that the IMI test has got two antibodies within it to ensure that it picks up both Neoformans and Gatti strains. I don't know if it works for rarer species of Cryptococcus, which are rare causes of meningitis, such as albidis or unigatulatus or Laurentii.
知道的是，英密公司生产的产品，它的抗体可以覆盖到德特隐球菌和新型隐球菌，这是两种主要引起脑膜炎的隐球菌。有其他更罕见的隐球菌可能不会被检测到。
Okay, so another very practical question, considering how large some of these countries are where this test might be used. Do we know much about the stability of the antigen in cerebral spinal fluid or in blood or in urine? Thinking of 3 or 4 days transport time to a reference center where this test might be carried out.
由于有些地区地域比较广，如果这个抗原在血液、尿液或唾液中，在运输途中，会不会因为运输时间过长而产生不同的结果呢？
The antigen is very stable. It is a carbohydrate. There are very few degrading carbohydrate enzymes in normal plasticware and transport media. So it definitely withstand transport into in the laboratory.
抗原是非常稳定的碳酸化合物，所以在运输途中并不是特别容易被分解。
Okay, very helpful, very useful. So a number of people are asking where can they find guidelines on not just the diagnosis of cryptococcosis, but also the treatment. What are the most recent guidelines on this topic?
有很多人想知道是有从哪里可以找到关于治疗或者是检测隐球菌有什么可以参考的资料或者是指南。
So the most recent cryptococcal guidelines were issued by the WHO for the management of patients with HIV and cryptococcal disease, and they can be accessed on the WHO website. On the LIFE website, there is a special guidelines section, and all of the guidelines for all the fungal infections are there, and they can all be downloaded, which may be helpful to you, for example, for cryptococcal disease in non-HIV patients.
最新的指南呢，你可以在WHO 的网站上下载，在我们的 LIFE 网站上也有各种关于真菌疾病的治疗和检测的指南，特别是关于非艾滋病和非脑膜炎的那个病人的治疗的指南。
You have actually discussed this to a certain extent, but the question is if you have persisting high cryptococcal antigen titre, what is the significance of that? And the patient is on treatment.
如果病人正在被治疗，然后他的隐球病抗原滴定数值非常高，这代表着什么呢？
So the serum antigen titer in patients with HIV takes a very, very long time to fall, and it's not a good measure of response to therapy at all. The spinal fluid antigen titer will fall gradually, but it takes a long time.
如果是艾滋病人，他的血清样品会需要非常长时间的治疗才能它的滴度才会下降。如果是积水液呢，它会下降的比较快，但是需要的时间也是非常长的。
So the lumbar punctures are repeated, for example, at 1 month, 2 months, and 3 months in somebody with cryptococcal meningitis. You would certainly be able to detect antigen even in successful treatment.
如果病人治疗后，你在1个月或者是几个月之后进行积水取样的话，你会发现它的那个滴定度还是可读的，还是挺高的。
One of the criteria that was used many decades ago for stopping treatment, which was always amphotericin and flucytosine in transplant patients, for example, was an antigen titer less than 1 in 8, because that was associated with a lower rate of relapse.
在 很久以前我们决定停止治疗的方案之一就是低度小于1:8，然后并且是有在用不同的药物在治疗。
We need more data on the non-HIV patient and the levels of antigen and relapse because this is not well documented now.
我们需要更多的资料和数据才能分析出来，现在的数据并不是特别多。
Okay, well, I think we can bring this Q&A session to a close. Thank you, David, for responding to these questions. And just to let all the participants know, the webinar that you've just heard with the questions and the answers will be available on UQ in a few days' time.
非常感谢大家参加此次研讨会，希望大家都能有所收获。今天你所观看的视频和问答将会放在优酷网站上，在2到3天之后，欢迎大家给我们留言。
Good.
Okay.
Thank you very much. Thank you, Sophia.
祝大家晚安。